the bone block over there, right? Don't have that much of defect. Okay, so we have put the bone and the bone graft will all over. While the spilling will be there, when we use all the muscles while sleeping, while whistling, while eating, while smiling, while speaking, right? So that membrane allows cell exclusion. I guess that is clear. Apart that you have to cram a definition. I guess what is cell exclusion through a membrane, that is clear, right? Okay. Then is tenting. So what is tenting? That the membrane is carefully fitted and applied in such a manner that space is created beneath the membrane, completely isolating the defect to be regenerated from the overlying soft tissue. So whenever we place a membrane over a defect, the membrane should cover the defect all over, right? So when I am talking about membrane, it is a very small membrane. It looks half the size of a bandit. They are not very huge, because whenever we do implantology, specifically for a single implant, I am not talking about full mouth cases, the defects are not very huge. If the defect is very huge, what do you call it as? You call it as no bone cases, and you avoid conventional implants in those, or you perform ridge augmentation and other surgical procedure. So if I am talking in terms of replacing a single implant, the defect is very small. The membranes what we use is the half the size of bandit what you guys have seen. So now the defect has to be covered with that membrane, covering the defect all over, and it should extend over the margins of defect. If you don't cover the margins, the membrane also shifts. The grafts also spills. So a proper stabilization of the membrane over the defect and covering the margins of the defect will allow the membrane to stay and perform its action. Right? So that is called as tenting. So this is what I have discussed, that it is important to extend 2 to 3 millimeter beyond the margins of the defect in all the directions. Right? Okay. Have you read about excisional biopsy? How do you do an excisional biopsy? Exactly. Safety margin. You take the healthy tissue also. Right? So, the same principle. When you put a membrane, you have to extend 2 to 3 millimeters away from the defect also. Right? Okay. Then scaffolding. So, membrane what you have applied in the form of tent, that acts as a scaffold. Right? What is scaffold? It is a surface which allows the holding of the blood clot. And if you hold the blood clot, it performs what? What blood clot does what? Acts as a medium to start your secondary healing, wound healing. It allows the progenitor cells over the membrane and migrate from adjacent bone or bone marrow. Right? So the fourth principle is stabilization. So whenever we are performing the surgery and we see that the membrane cannot be stabilized over the defect, we have to stabilize it physically, either using the sutures, we tie it with the mucoperiosteal flap, or sometimes we use stacks, that is also called as bone tacks. Right? And the framework. In areas such as dehiscence or fenestration, the membrane collapses. Membrane is a very soft membrane, right? We usually use resorbable collagen membranes. So sometimes whenever the defect is more and you have filled it with a bone graft, the membrane tends to collapse, right? So now what do you need to hold the membrane? Titanium meshes, which is called as framework support, right? And this is usually done in huge defects. So coming to the indications for GBR, I guess the 5 principles of GBR is clear. Okay. So coming to indications, which we have already discussed. So local alveolar ridge deficiencies, which could be horizontal or vertical. Osseous fill around immediate implants, cases where we have got dehiscence and fenestrations, bone defects associated with a failing implant, right? Wherever you retrieve a failing implant, of course there will be bone loss, there will be a bone defect, and in those cases we perform bone graft, usage of membrane, and hence which is something called as guided bone regeneration. Also, in case of residual bone lesions, wherever you see an abscess, wherever you see a cyst, bone loss, and hence the use of GBR. And also to aid in repair of sinus membrane perforations. These are very technique sensitive surgeries. I have never done a sinus membrane repair in my life. It is usually not needed. Okay, so if you see this case, can you see a soft tissue lesion over here? Of course, it is associated with the periapical lesion for the tooth. When we extract, we see a defect, we put a graft, we put a membrane, we stabilize the membrane with the tacks, and then we close it. So here we haven't done an implantation directly or at the time of GBR. So, what are the types of membranes what we use? So basically there are two types of membrane. One is resorbable and one is non-resorbable. Which will you prefer and why? Resorbable. Why? Pardon? Okay. Okay. So for huge defects, non-resorbable. For smaller defects, you say resorbable. Okay. So usually a membrane, how much time it takes to resorb? When you say that you are using Vicryl, right? We use Vicryl in mouth. What do you think that how much time it takes to resorb? Have you ever followed your patient for that? It takes minimum 49 days, right? So whenever you follow up your patient, you should always call them after 2 to 3 weeks also. Just for pain bhi khatam ho gaya. So Vicryl is called as a resorbable suture, but it takes more than a month to resorb. Your membrane takes more than 6 months to resorb. So a large defect or a small defect will not decide that we have to use a resorbable or non-resorbable. Somebody said here that we use a non-resorbable because you don't want a second stage surgery. What happens whenever we use a membrane, it is a see-through of a membrane through a wound. So if a membrane is poking out of the oral cavity, of the ridge into the oral cavity, it has got 100% chances to get infected, right? So a non-resorbable membrane, if it is seen through the wound, it has to be taken out, right? So the choice of membrane is always resorbable, which is 100% made up of collagen, and collagen is the main tissue forming unit, right? So these are the properties of membrane, that it should be biocompatible, it should be cell occlusiveness, space making, tissue integration, and of course clinical manageability. Whenever you say clinical manageability, what do you mean by clinical manageability of a membrane? When you take it out of the packet, it should not stick to your instrument. It should be not that fragile that you take it out with the tissue forceps and it breaks. So these are the properties of a membrane that you choose on, right? Okay. So the bone filler materials may serve several purposes in guided bone regeneration regeneration procedures. So the filling material, what is it called as? Bone graft. We discussed it yesterday, that we'll be talking about the bone grafts, right? What is the type of bone graft? First type, autograft. Autograft means from the same patient. What are the harvesting site of bone graft? Palate. Okay. One is palate. Iliac crest. Okay, iliac crest, we'll come back to that. Tuberosity. Mandible. Mandibular symphysis. Mandibular body. Ramus area. right? These all are the donor areas, right, to harvest the bone grafts. But what is an advantage, disadvantage of, what is an advantage of an autograft? All the three properties: osteoconductive and correct. And the best part is there is no cross infection. There is no rejection of the graft if handled nicely during the surgery. But what is the main disadvantage? Of course, you have created a donor area which is going to pain. You have to maintain. And when we talk about implant procedure has nowadays shifted to more to be considered as an aesthetic procedures, right? So you never you never harvest a graft for implant procedure through tibia, through fibula, through ribs, through iliac crust. You don't need that. You do not need that much of bone for the implant procedure. This is like that you should know that these are the areas where we can harvest the autograft. But usually to do an autograft harvesting in the implant procedure, we use bone scrapers from the area where you are doing the implant procedure. For an example, if you are restoring the central incisor, the bone scraper is a very small instrument which goes more apical towards your anterior nasal spine and you scrape it. Okay? So the donor and the surgical area almost remains the same. Okay? And the amount of harvested bone graft, it is not more than 0.5 cc. So nowadays what we do is we mix autograft and xenograft so that the volume of the bone graft which you need is more and you do not harvest more of autograft and creates comorbidity of the donor area. Right? Okay. I'll show you the pictures for the harvesting. What is an allograft? From the same species but from another person. So do we see allografts in India? No. That needs a lot of medical sciences. It's only US which does allografts. Earlier Tata Memorial Hospital was sending us the allograft. Still they send, but there's a lot of documentation which is required. So this hospital provide allografts on and off. Okay? And the major disadvantage of allograft is rejection, right? If it is not bagged, sterilized properly. Okay. What is an alloplast? That is easily available, very nice results, and it is delivered in lot many forms. Alloplast can be in a form of a block. It can be in the form of a paste, that is sometimes called as putty, or it can be in the form of granules, which is also called as morsels. So nowadays the most graft in dental implantology, what we do is alloplast, sometimes mixed with xenograft or sometimes mixed with autograft, right? And the xenograft is from other species, and the major species what we use is bovine, right? Okay. So these are the instruments we have been using for harvesting the autograft from the various sites. That is the chisels, the curettes, and what are these? These are trephines. So shifting from the hand-driven instruments to motor-driven instruments, right? So what do you do sometimes? That whenever you have an edentulous jaw, you use a trephine, you create an osteotomy and you use a trephine. And trephine harvests some of the bone for you. You put an wider implant and you use that autograft in the defects if you have it in the same patient at other areas, right? Now see this, such procedures of harvesting an autograft from the chin area, right? Do you think for placing a single implant in the upper maxilla, do you want that part of bone, right? So such procedures are only limited to ridge augmentation cases whenever we do full mouth cases in atrophic jaws, right? So, this much of bone harvested from the third molar area, right, external oblique ridge, will 100% cause lot of post-operative discomfort to the patient, which my implant site will never cause. So we do not do lot of autografting in implantology until unless you are treating an atrophic maxilla or mandible where you need ridge augmentation or distraction osteogenesis, right? Okay. So this is how you harvest the bone, you mix it with the blood of the patient and then you put it in the defect. Now, these are the common GBR techniques what we have been doing. Now, look at the case here. That is an upper central, right? If you see, we have accommodated an implant which is just 3 millimeters if you close this soft tissue. So, the coronal position of the implant is clear. But do you see the buccal bone missing over here, right? We are mixing a xenograft with an alloplast, which is xenograft is also in the formation of morsels and alloplast is also available in the form of granules morsels. The morsel size varies. The thinner the morsel, the better the graft. Why? More surface area, less voids. If you mix bigger particles, of course the voids will be more, and again they are going to create internal jump spaces for your mesenchymal cells, right? So we are mixing the two grafts over here. We place a graft and we put a membrane and we have secured the membrane with a tag, right, and suture it. Now look at the stage 2. Look at the thickness what you have achieved. The tag is over here. Look at the fullness of the buccal plate, right? So such kind of buccal contour restoration with alloplast and xenograft and a simple collagen membrane is more easier than harvesting an autograft from the chin, creating a donor area, securing the huge plate over the recipient side, right? Now see the difference. Earlier it was this, and look at the buccal fullness what we have achieved after 6 months, not 3 months. Everybody, we have studied that you put an implant, you wait for 3 months and then you find it integrated, right? This is what we have studied when we read the story of Brenmark, right? But this 3 months integration is with conditions applying, right? If you have good healthy bone, if you have got good soft tissue, if your patient is not diabetic, if your patient is not smoker, is not nicotine dependent, then only this 3 months application is applied. This rule is applied. Whenever we use bone grafts, whenever we use membrane, you have to allow minimum 5 months to get into stage 2. Right? Any questions about GBR? So, let us discuss then cases. Okay. A broken premolar, extraction. Correct? Do you think that you have sufficient soft tissue and hard tissue over here? No. Why? Why no? Look at the soft tissue. It's all pink. This is buccal, this is lingual. This is what I am asking. When you see the soft tissue over here, right? Don't you think that this is tempting you? Okay, there will be a lot of buccal bone over here, but we have done an extraction and we have raised a mucoperiosteal flap, and you see that there is thinning of buccal cortex, right? So you take the X-ray what drill is this? Exactly, it's a parallel pin, not a drill. So you take an X-ray with the parallel pin to decide the final destination for the implant. You've placed it with the GBR, with the bone graft. So choice of bone graft will be what all bone graft do you know? The name of a bone graft which is available in the market. No bone putty, bios, rocky bone. Right? These are all the market names of the bone graft which is available in the market. Right? So shall we discuss the case first? So पहले case discuss करें जो आज इसमें present करना है. Right? So who wanted to know about socket shield? What do you know about socket shield? What is socket shield? Anybody? Come on. You preserve a buccal root. So socket shield technique is done only in the upper anteriors. Why do we do socket shield? As the name suggests, you are preserving the socket by preserving some part of the root of the incisor, so that your soft tissue fullness is seen whenever you give your provisionals. So it has to be done only in the upper anteriors. We do not perform in the lower anteriors. Right? So it's the root which is preserved. Now see this case. A broken central, good soft tissue fullness, buccally as well as palatally. How do we extract it? Yesterday we had decided we divide the root into two equal parts using a long shank carbide burr, not diamond burrs, because it is going to create lot of diamond dust, right, which is going to infect your osteotomy and will allow your implant to die, right? So very carefully what we have done is we have separated the root into two equal parts. And what do? I put my laxator and remove this palatal part of the root. And do you see this instrument? This is called as a shield protector or a shield prepare. It's a hand-driven instrument which allows you to stabilize the remnant part of the root, and you can take a normal round diamond burr and shave this remaining part of the root, right? So it's not the entire root which is to be prepared. It is only the buccal and coronal part of the root which stays in the socket. What happens if we remove this part? There will be chance of buccal wall fracture. At the same time, this soft tissue contour will be lost because you fracture the bone, the buccal plate is gone, the soft tissue collides, it collapses, which will not give you a good emergence profile to your provisional or a final crown, right? So we have removed the palatal part and we have shaved the coronal buccal portion of the root using this stabilizer, right? Now see this, do you think that the shield has been prepared? I again repeat, this part of the root is not till the apex. It is only in the coronal part. I will show it in the IP also, right? And then you put an implant, right? Now see, the thing to be noticed is there is a potential gap between my implant and my prepared shield. Why? I want the blood to accommodate over there and the bone to be formed. My shield is only for the soft tissue zenith. My shield is not allowing any bone formation around the implant. So this gap between the shield and the implant has to be maintained so that the blood clot settles all around the bone, or you can use a graft also over here. But why a graft when the gap is less than 2 millimeters? We spoke about it yesterday, right? Unnecessary नहीं हमने कुछ करना होता surgeries में. So my gap is not more than 2 millimeters. I am creating a beautiful gap of 1 millimeter between the shield and an implant, allows my blood clot to settle over the implant surface and then performs the secondary healing and an osseointegration after 3 months. Right? Okay, another question. Instead of preparing this shield buccally, why didn't we prepare the shield palatally? The purpose of socket shield. Only the soft tissue zenith. Only that buccal fullness what you want your anterior aesthetic zone should have. Right? Placing an implant. Look at the length what I have mentioned purposefully. 16 millimeters. Why? Primary stability from the apex, from the anterior nasal spine. So I am putting purposefully a longer implant so that I can have a primary stability, a torque more than 50 newtons, and hence I will give the provisional at the chair side. Right? So if you summarize this case, we have extracted the tooth, divided into 2 equal parts, prepared the shield, slowly we have removed the palatal part, maintained the gap between the implant and the shield, have given the provisional simultaneously. Can you appreciate the remnant of the shield here? You want me to? Can you appreciate over here? A small thin enamel and dentine shadow, what do you see? Which doesn't extend to the middle third or the apex of the socket. Right? So the shield has to be limited over the coronal part only. And your implant is taper implant. Right? Even if you leave your shield at middle third, it is not going to touch, because your implant becomes narrow as soon as it goes into the osteotomy site. Okay. So the second, I guess I have a provisional also for this case. Let's see. Pre-op broken of your left central incisor, right? RCT treated teeth, totally broken. Palatal view. I have to maintain this buccal fullness. Preoperative X-ray. Do you think an easy extraction? No periapical lesion. The tooth is not going to, the bone is not going to give you the tooth very easily. So of course you have to section anyhow. So see the margin over here. Your apex lies here. Your anterior nasal spine or the floor of the nasal cavity is almost 10 to 12 millimeters away. So I am going to take an advantage of this fresh bone also. Right? Root sectioning in buccal 1/3 and palatal 2/3. Why buccal 1/3? Why not equal? Exactly. The tooth is tapered. Right? And you put less part of buccal because anyhow you're going to prepare the shield. You have to shave it so that you can maintain the gap between the shield and the implant. So the lesser cutting towards the buccal and keeping the palatal part more thick so that you can easily catch hold of it with a root forceps, rotate it and pull it. Right? This, you know what? This kind of sectioning of tooth, it needs lot of patience and you have to give time. And what did I told you yesterday? What do you use? You use your eroters. With learning of those buttons on your dental chair, which reduces the compressor force, right? The pressure, the PSI. Because if you use long carbide burrs over the eroders, they are going to break. Long shanks होती है, इतनी स्पीड में चलेगा तो वो टूट जाएगा. So you have to control the compressor system and then use the eroders, right? See how beautifully you section, and I have taken out the palatal root. Now what is left? Just the buccal part, right? And did you see we did not touch the soft tissue over here? I haven't used my periosteal elevator to raise the mucoperiosteal flap from the buccal or the palatal area. Just working inside the socket. How does it help? It preserves the vasculature. When you haven't raised the periosteum, the implant will have a better life, better healing, less post-operative complications. Again, shield shaping, using that hand instrument. This is a very nice instrument what you get from Jewel Dent. Okay, and it's online also. You will buy it from those dental carton. So, sometimes when I never had this instrument, I was supporting it with my periosteal elevator only. But I told you yesterday, when you have got good gadgets, when you have got good instruments, they might make your surgeries very easy. Right? Labial shield, again the thin part, and see here you can appreciate that it is only confined to the coronal area. It is not in the middle third or in the. So for example, if you see that there is a mid fracture, you can take a burr and start shaving it, and just leave the coronal part and shave the entire apical and the middle third. Facing an implant where the torque has come around 45 newtons, which is absolutely okay for my immediate loading and giving a provisional. And can you notice the depth of the implant over here? Do you think it is very deep? It is 5 millimeters deep, and then you keep on asking for a abutment which has got a higher. So I guess the prosthetic phase is still due for you guys, right? So when you go through this prosthetic phase, you'll understand that there are different types of abutments, and you struggle for abutments for your prosthesis. But when your surgery is planned according to your prosthesis, you don't ask for some bizarre abutments from your implant dealer, right? So if you see the positioning of the implant, it is absolutely just 3 or 4 millimeters from the soft tissue, right? Again, I told you that I am going to engage it in the fresh bone for my stability. Now see this here. It is not very deep inside the bone. So when we started this case, the patient had a zirconia on it. So we have preserved that implant for that crown, and we are using a plain stock abutment, which is also called as the transfer abutment. And I have adapted the same zirconia crown over this transfer abutment in the patient's mouth. Can you see that? I've done this chair side work. I've cut it, and here I am going to restore it with a composite. This cut part, I can just put some composite over here and allow this hole to remain that way, so that I deliver a screw retained provisional. Right? Now see the final prosthesis. This is the screw retained provisional prosthesis. Do you think it is bad? Do you think it is those pictures which I showed you when we started the presentation? Look at the margin. It is so nice. And you gave the tooth the same day. That is actually called as the implantology. The beauty of giving the implant the very same day and giving the crown very same day. This is what the patient asked for. And of course, it doesn't apply to all those or every case. It varies from patient to patient. But 80% of the patient, they want the teeth and the implant the same day, specifically in the aesthetic zone. Okay, now the question comes, if we would have done, okay, let me complete this first. So this was the provisional what we gave. Patient came after 3 months. I told you that I have left a hole behind. This is a hex driver which goes behind the provisional. We take it out and I put a scan body in the patient mouth, taken a scan. This is the printed cast which is called as a digital impression. Look at the tissue topography after 3 months. Right? Can you see the soft tissue? This can be only achieved when you do a socket shield. This can be only achieved when you give a chair side provisional. If you don't give a chair side provisional, you don't achieve this kind of tissue topography very easily. You have to do a lot of soft tissue modulation. Right? And look at the final prosthesis. The palatal view of tissue topography. Very healthy soft tissue. Right? We got a screw retained zirconia for this patient. Final prosthesis. So the provisional and the final almost look same. Right? Now the question comes that what if we would have done a GBR in this patient? You've preserved the socket, you've done a socket shield. But what if the present tooth had a periapical lesion somewhere and you would have found a fenestration? What decisions you would have taken? So one by one. You understood the scenario? Right? So for here, you have a socket shield here, right? You've made an osteotomy site, you've put an implant. Now you see that, okay, when you using your hand, and now you can see that the bone is missing. Or you take a probe inside the osteotomy site or a periosteal, a smaller periosteal, and you start feeling the tip of the periosteal elevator from the buccal side at some part of the osteotomy site what you have prepared. Understood? So what would you do? You would do a GBR? No? Or you would do it, you will go with the socket shield only. If you do a GBR, your socket shield principle goes off. Right? Socket shield is only in what cases? You don't raise a mucoperiosteal flap. Right? So what I would do is, if I have achieved the primary stability from the apex of the implant and my implant is not coming out through the osteotomy site, I leave it as such. My entire implant is shielded with bone. I have not raised the mucoperiosteal flap. The implant stability has been achieved. I'll close it there only. Rather, I would load it also if the torque has been achieved more than 40 newtons. So it's not like that wherever you see a defect, you jump on the bone graft and the membrane. Right? But if the similar defect would have been in the coronal area, like a dehiscence, and you don't have a bone plate to support anything, of course you have to do a GBR. Right? Okay. So we take a tea break. 11.
Ask if you have any doubt till now. Because the GBR and the socket sheet both are different techniques. So it should be clear in the mind in which cases we are going for the GBR and which cases we are going for the socket sheet. Can we do it provisional today for the today's surgery?
We can, sir, if we have program, we can hold.
So, इतना ऑनर इस तरह से
ठीक है, provisional बना लो. So okay, so what do we conclude from yesterday's and today's lecture? You remember the 6 golden rules we discussed? Everybody remember that? What were the golden rules what we discussed yesterday? No active infection. Everybody has noted down. Prosthetically driven placement of the implant, not the path of easiest insertion. Primary stability is must, and from what all areas you achieve it, 3 mm apical. And you have to graph when gap is between more than 2. Exact. Fifth, that is remember one. And you have to curate the granulation tissue very gently without breaking the bone. Right? Okay. And submerge implant in socket by 2 to 3 millimeter to take care of emergence profile. I've added this golden rule later because today only we have seen that how do we do implant in the aesthetic zone, right? So 2 to 3 mm implant has to be embedded in the socket to have a good emergence profile when you do the provisional or the final crowns, right? Now see this case. Do you think that the implant is very nicely embedded in the socket, right? two equal parts, right? Using a burr. And we have a interradicular bone over here, right? Placing your implant in the interradicular bone to achieve a primary stability. What different? Now see here, lot of bone graft we have secured around the implant by jumping spaces. And instead of closing it, because see this, lot of granulation tissue while extracting, after extracting the molar, preparing an osteotomy site, and I thought that I'll not be able to close this soft tissue. Plus the bone was missing. So we have added a bone graft, and at the same time, I have created a kind of customized healing abutment. What did we do? I took a transfer abutment, I've taken a composite, done a lot of chairside work, I've removed the sharp edges of the composite and secured it over an implant. So it has done two things. What two things? It has given a closure to us, secured my bone graft, and at the same time it is going to modulate the soft tissue when we do the stage 2. So if you see the soft tissue profile, now see this, once the soft tissue had healed after 3 months, I have modulated more of composite and given it as a provisional. After 3 months, when we remove this, look at the tissue topography. It's a beautiful tissue topography for your final crowns, which will have good soft tissue in it as well as good soft tissue health and will not harbor food particles. See it from the buccal and the palatal area, nice pink epithelialized soft tissue, right? And a final crown with soft tissue zenith emergence profile. Final crown, right? So now we discuss the doubts what we have spoken about till now. Do we have cases to discuss? कितने लोग इम्प्लांट डाल लेंगे अभी जाके? Now today in today's class, how many of you have done implants? One. Which area? 4-6. That is the mandibular bone. 2-3, 2-7 also. So tell me the most difficult thing what you found in 2-7. हाँ बताओ.
मेरे साथ हुआ था कि मैम ज़्यादा टॉक लग जाता था उससे एक्सीडेंटली तो वो इम्प्लांट था और वो थोड़ा सा साइनस की तरफ ज़्यादा चला गया था.
ओके.
तो फिर उसको वापस फिर बाहर इम्प्लांट को लाना पड़ा था हमको आउटवर्ड टॉक लगा.
ओके.
सो दैट वाज एंड मैम विजिबिलिटी नहीं थी. विजिबिलिटी में बहुत प्रॉब्लम आई थी एंड एंगुलेशन पेशेंट के क्योंकि माउथ ओपनिंग भी थोड़ा सा प्रॉब्लम है.
Was it an immediate extraction case?
No, delayed.
Delayed one. So you had an edentulous jaw, and where you had done an incision, you have prepared an osteotomy site, and then you did an implant, right? Okay. So do you think that did you over prepare the osteotomy?
No, ma'am. The length was okay. I've taken multiple X-rays to
Okay.
ensure that I've not perforated the sinus floor. But while I was placing the implant,
Did you see that kind of a white line? This, like if you see here, this is the floor of sinus. Did you see that your drill was not crossing the floor of sinus? It wasn't.
yes,
But when you had put the implant you saw that it was going in the sinus.
yes,
How did you know that it was going into the sinus?
ma'am. The sinus flow, ma'am, from the X-ray it was visible. The sinus flow was the implant has gone beyond the sinus floor.
So if you drill 2 mm away from the sinus floor and you are using passive implants, even if you're using an inactive implant, the 2 mm of bone cannot be drilled or surpassed by a implant. So either there is an over drilling, that you are very close to the sinus floor, and when you take the tip of the implant, and if that implant is a tapered implant where the tip is very active, there is a probability that the sinus floor lifts it with the implant itself. But if you have a good chunk of bone that is maybe 1.52 millimeters, none of the implant can cross that.
So it's very close to the sinus.
So the drilling was very much close to the sinus floor, and then you would have seen that the implant torque is getting reduced, right? So if you are in the bone, the torque is going to increase. But when you're winding the implant and the torque is reducing, the resistance is reducing, there are two chances. Number one, if the implant is going deep, you are out of your zone. Either you have come out of the cortex in the mandible, or you are entering the nasal cavity, or you are entering the sinus. Or the second probability is that the implant starts rotating inside the osteotomy only. And even the passive implant has got the efficiency of cutting the walls. So what it does, you keep on rotating it inside and it starts shaving the bone, and hence the torque goes down. Right? So the more and more you use those torque ratchets, the different implant system when you use, so you will be able to know that where you are going wrong. For your complication that you are going into the sinus, I would suggest a sequential X-rays. First drill X-ray, second drill X-ray, parallel pin X-ray, and you just keep on watching your sinus flows. Right? And then you would have not landed into the complication. Of course, visibility is the major issue for 2/7s and 1/7s. It is for all the endodontic procedures also that you don't tend to see your maxillary molars. Right? Any other complication?
No, but while I was drilling, the space was very less for the drilling.
What system you were using?
GMI.
GMI. Okay. So see what happens. Every implant system has got different kits. Right? GMI is a European implant where the drills are not length ends. The drills are bigger, and you have got the shavings or the markings on the drills that the first mark is 6 mm, then it is 8, then it is 10, 11, whatever it is, right? But there are certain companies which gives the shorter drills. That 8 mm drill will be different, 10 mm drill will be longer, 12 will be more longer. So such drills are easy to use. But it varies at what system do you use. None of the European implant system produces length end drills. Or the Korean system does it. So when you do such long drills in multiple cases, then you can always learn that you can go a little angulated into the bone and then straighten your drill. Or ask your patient to open wide or use a bite block. Any of 2/7 cases, 1/7 cases are difficult to handle. Right? Have you loaded that implant? No. Any other questions? Please. Yeah. No, not at all. A very good question. You never do socket shield when the tooth is infected. No, not at all. Socket shield are to be done only in healthy teeth, fractured teeth, where there is no periapical. Whenever you have a periapical, the case shift to GBRC. You have to raise the periosteum, you have to use a membrane, you have to use a graft. Right? Very nice. Socket shield are done only in healthy cases. Healthy cases means that you have an RCT treated tooth, there are proximal caries, and the crown tends to fracture. Now you have a healthy root inside. Right? Any other question?
When we shave the apical third of the root,
Coronal third.
so then the shavings did not make it infected also.
No, nothing. That is why the shaving is what? Tooth. Right? The burr residue allows your socket to get disease or get infected, not the toothpaste. And you're using it with the aerota with water. and the suction is also wrong. Right? Any other question?